Speaking of care transitions, to the debate stage and bring up Dr. Jeremy Cushman, who is going to take on the second part of this morning's activities. Thank you so much.
All right, good morning. Time to change it up a little bit. I'm excited to be here at NECC, excited to hear about the opportunities that we have within our communities to improve the entire care of our stroke patients. Excited to be part of this leadership team, and most importantly, excited to kick off the debate stage at this first debate. So let me let you all know the ground rules. The ground rules are this. We're going to have three really timely and interesting debates for you today. During each of the following debate sessions, each side will be allotted just 10 minutes to present their case, and I'm here to push them off if they exceed those 10 minutes. They'll then have 5 minutes for a rebuttal on that, and then we'll conclude each debate with about 5 minutes of Q&A and closing comments. And not to be rude to anybody, but it will be 5 minutes of Q&A, which generally means like 2 questions at the rate we ask questions. So just warning you, it's not personal, it's just we got a schedule to keep to. All right, so I'm going to be moderating our first debate. It's transport of suspected large vessel occlusion. What's the right protocol for bypass? Now, presenting in favor of the Mission Lifeline Stroke's severity-based stroke triage algorithm for EMS is Dr. Matthew Siket. Dr. Siket is an emergency physician at 3 stroke centers here in Rhode Island, including the Rhode Island Hospital, a comprehensive stroke center, as well as the Miriam Hospital and Newport Hospital, both primary stroke centers. He's also a member of the Rhode Island Stroke Task Force and is actively engaged in research efforts focusing on the rapid recognition and cost-effective evaluation of cerebrovascular emergencies. And then presenting in opposition of the algorithm, Dr. Andrew Asimos, who serves as the medical director of the Carolinas Stroke Network. Notice the Carolina thing here, huh? Where he oversees acute management of stroke patients seen across a large network of hospitals owned or operated by Carolinas healthcare system, which is one of the largest not-for-profit healthcare systems in the country, including 2 endovascular centers located in the metropolitan region of Charlotte, North Carolina, and over 20 acute stroke-ready or primary stroke centers. So thank you both very much, gentlemen. We're going to start with the opposition. Are you ready to rumble?
Ready to rumble.
Let's go.
Peter, it's not going to be that bad, trust me. If I can get my slides up. So my goal is to say enough provocative things in the next 30 minutes that tomorrow during Stroke Tank I can convincingly assume the role of Mr. Wonderful as one of the judges. Can somebody get my slides up? And Pam and I would also like to complain that North Carolina was not a potential choice for what state you're from. So, first of all, here's the title, and I already have a problem with the title, okay? We're not bypassing hospitals. We are routing patients to endovascular centers, okay? And that really is important. I mean, there's sensitivity to this language, so I prefer the term, routing rather than bypassing hospitals. You can read about my disclosures in the program. So, these are the scenarios. So we're not talking about the mobile stroke unit today. That's another debate that'll take place at the ISC that I look forward to. We're not talking about drip and ship when there's not an option. We're talking about the scenario where there's a comprehensive center, an endovascular center that is a potential destination hospital, but there are other lower level centers. That's what we're talking about today. So I think everybody gets it. This makes sense. We know that, over half of the population is within a reasonable drive time of a hospital, thrombectomy capable hospital. And we also know that patients don't do as well when they need to be transferred to an endovascular center for thrombectomy. Reference the paper Froller that just hit the press with circulation, with some data from the Stratus registry. And this is essentially what we're talking about. So, suspected stroke symptoms, access CMS, it either gets dispatched as a suspected stroke or the paramedics arrive at the scene. They think the patient's having a stroke. They do some type of an assessment, stroke severity assessment. If they're within a 6-hour window or some certain time window and the drive time is reasonable, they get routed directly to an endovascular center or a comprehensive stroke center. Otherwise, they show up at the closest hospital. So that's what we're talking about. And that's essentially what's in the Mission Lifeline protocol. You're going to hear more and more about this as the morning goes on. I was on the committee that that created this, I had some, concerns about, is this ready for prime time or not? But it's out there. So I think these are key questions. If you're going to get in this business, you should be asked these questions and be able to answer them, in my mind, before you do this. So first of all, we need to figure out, what rates of over triage. That means patient with a non-LVO gets routed to an endovascular center, bypassing other hospitals because of non-specific screen. And then the opposite, what rate of under triage are we willing to accept? How many LVOs are we willing to show up at a non-endovascular center? We've answered that for STEMI, we've answered it for trauma, and we need to answer it for stroke. We need to have these conversations. Is it going to be 15%? Is it going to be 30% when I reference over triage? But we got to figure that out. Sensitivities and specificities for EMS dispatch. I don't think that dispatch belongs in the algorithm, honestly, right now. I think it just adds too much noise, and we can talk about that. I think you need to rely on what they find when they get at the scene. You got to know what the prevalence of large vessel occlusion, stroke, and or hemorrhages, if they're going to be the routing population, is. And the reason for that is the predictive value is a product of two things. It's a product of the prevalence of disease in the population that you're screening, and it's a product of the sensitivities and the specificities of the screens. So you take a low prevalence of disease population and you apply a screen that has poor sensitivity, or specificity, that is a recipe for over triage. And again, I think we need to understand what rates of over under triage we're willing to accept. We need to know what the inter-rater reliability of these screens is. So if 100 paramedics are going to assess a patient in the field, how many of them are going to give them a LAMS motor score of 1 versus a LAMS motor score of 2 for the arm drift? And that's important, because if you're going to route based on a LAMS of 4 versus the 3, and half of the time, half of the paramedics are going to give it a 3, and half of the time, half of the paramedics are going to give it a 4, that's a big problem. There's not one paper published that I'm aware of that has looked at the inter-rater agreement of the independent elements in any of the screens. And then the time stipulations. Dawn's going to be out in 2 months, or 2 weeks. Geez, what are we going to do? We're going to expand the window, which is going to probably mean even more over triage. So a lot of important questions. Others are going to talk about the specific Mission Lifeline screen, or algorithm. Just a couple things. Where do you start? So the algorithm seems to suggest you should start with the population of dispatched as a stroke, and or paramedics arrive at the scene and there's a suspected stroke. So when we thought of doing this in North Carolina, we said, well, geez, what's the prevalence of disease in that population? We didn't know, and I said, okay, well, let's do a study before we start to do this. And I'm extremely proud of this acronym that I thought of, the Plummer study, which is, you can see, prevalence of large vessel occlusion stroke, Mecklenburg County emergency response. Is going to be published in Stroke in a couple months. And we basically looked at the population that appears to be the population that Mission Lifeline suggests. We did this in conjunction with our EMS agency, the other competing system in town. We looked at over 2,400 patients, and we found that the prevalence of large vessel occlusion stroke was about 5% in our population. And you hear people talk about what they think it is. I mean, we know in a hospitalized population that, with confirmed ischemic stroke, it's going to be somewhere between 24 and maybe 35, 40%. So it sure as heck isn't going to be any higher than 20% in an undifferentiated population. So pretty low prevalence of disease. Dispatch, the sensitivity and specificity of dispatch is so poor. I think here in Rhode Island, the mantra is waste gas, don't waste neurons. Well, I'll tell you, in Cleveland, they are wasting plenty of gas because the mobile stroke unit gets called off 2/3 of the time where it initially starts driving to a scene because the dispatchers were wrong. So dispatch definitely adds some problems with this. Serial use of stroke screens. So if the algorithm says do a stroke identification screen, Cincinnati screen first, or LAM or Los Angeles pre-hospital stroke screen, and then if they fail that screen, drop them out and go ahead and do the stroke severity screen. Well, that to me implies that the sensitivity of the preliminary screen is 100%. And nobody's actually ever looked at the serial use of screens. We looked at that in Plummer. Not everybody got a stroke identification screen. 3% of patients were missed. If you actually throw those people out, the prevalence of disease increases to 11%. But so I do think there's what we need to do. We need to somehow increase the prevalence of disease in the population that we're screening, and I think we've got opportunities to do that. Zero use of stroke screens is a real thing. This is Polk County, Florida. Florida is the wild, wild west when it comes to, what's going on. I mean, every other hospital is a comprehensive center. Craziness. Hopefully nobody here from Florida. All right. Stroke severity screens. A lot of folks are going to talk about the stroke severity screens. You're going to be hearing plenty about these. I'm a little surprised that the CSTAT even made it into this list based on how the CSTATs performed. So here's all the screens. Every time you see a 1 or a 2 next to that, what that means is it's a graded response. So it's a 1 for a certain level of, for example, arm weakness, and it's 2 for another level. Okay? Well, somebody needs to show me the inner rate or reliability of all this stuff. Okay? And it doesn't exist. At least it doesn't exist in the medical literature. You got the sensitivities and the specificities. Those are based on the derivation populations of the screens. So, and again, look at that. I mean, CSTATs, in the derivation population, the specificity of the CSTAT was 40% specificity. I mean, we know these screens are going to perform worst in the population that they're applied to. By the way, this is the predictive value. If you throw the predictive values, or excuse me, the sensitivities and the specificities that have been published so far on a 5% prevalence of disease or up it up to a 10% prevalence of disease, that stuff in yellow is the predictive value. So I think, we need to be willing to assume a certain rate of over triage. And then the last thing, has to do with, the time stipulations in this. Right now it says 6 hours. Okay, what's it going to say 2.5 weeks from now when Dawn is out? And what's it going to say, 3 months from now when Diffuse 3 is out? Are we going to start screening patients for, between 0 and 24 hours? That's a lot of patients that are going to be routed. A lot of, non-specific screens. Huge issues of over triage. And, I'm in Charlotte, North Carolina. We've got 2 comprehensive centers there. We are really sensitive to over triage. We don't have 5 comprehensive stroke centers on the same block. So we don't need any extra patients consuming beds for the patients that we really need to manage. So I think we've got to be very careful about how we do this. And, this is in our future. Absolutely, it's in our future. I get the concept. But, what we need to be doing now, everybody needs to be figuring this out, different models. We shouldn't all be adopting this one model that, in my mind, is unproven. We need to be experimenting, and people need to figure out, what's the best way to do this or not. And with that, I'm going to let Matt take over. And 9 seconds to spare.
Wow, that was great. Thank you, Andrew. You taught me a lot just now. And thank you to the NECC and the Planning Committee for this opportunity. It's pretty humbling to be up here with you guys. Do we have? Oh, where are we? Okay. I certainly am humbled to be up here with Andrew, and I certainly have disclosure envy, if nothing else. But I'm sure all of you are kind of sympathizing with me right now. Why am I up here about to get mauled? You guys are all like these spectators in the back just waiting to see a mauling. And you might. But either way, I think we have a few things in common. I may lack a lot of the experience and knowledge of my opponent, but we're both emergency physicians, and we're both somewhat involved in implementing stroke systems of care regionally. And I'm really proud to be a local, right? So I work here. I actually work about a mile down the road in Newport. It's a primary stroke center, and up in Providence at another primary stroke center, the Miriam Hospital, and our regional comprehensive stroke center at Rhode Island Hospital. So I kind of represent both perspectives. I am the referring physician for large vessel occlusions a lot of times, and I'm the receiving physician a lot of the time as well. And I absolutely think this is the best step. It's an appropriate first step, and it's a move in the right direction. I hope to show that. So I, like many of you, remember a couple of years ago when these trials were published, just looking around thinking, oh my God, how are we going to offer this new standard to all of our patients? We have to be able to offer the same standard across the catchment area, not just to those that are fortunate enough to arrive to the comprehensive, the endovascular center first and early, right? And that's because we know there's a very critical time-dependent treatment effect. We saw this with the TPA trials 25 years ago, and we're seeing it again now. The effect diminishes, it looks like, right around 7 hours, and it's true across the whole spectrum of modified Rankin scales, right? And what we don't know is just how great this potential benefit can be. If we can shift this x-axis further to the left, just imagine how much better the results are going to be. And I'm proud to say I play a small part of a very excellent team here in Rhode Island, and we've had some successful onset to reperfusion, endovascular reperfusion times less than 70 minutes recently, right? So I'm excited to see in the near future how much more green we can add to this graph. And I don't need to tell any of you that time is brain, right? You've heard this mantra all before. A drop of brain, a day of life. And with large vessel occlusion, save a minute, save a week. Well, the number I want you to remember is 90 minutes, because right now in Rhode Island, that's the difference. If you route to your primary stroke center, it's actually an additional 90 minutes on average than if you bypassed, if you triage, diverted to the comprehensive stroke center. And that 90 minutes, what does that translate to? That's over a year of life. That's well over a year of life. And that's over 150 additional patients of every 1,000 treated, functionally independent at 90 days, right? So this isn't small stuff we're talking about. This is big stuff, right? But why are we failing our patients? He showed us that just over half of patients in the U.S. are within 60 minutes of an endovascular capable center. But if you look, just about everybody here, almost 100% of the Northeast is within 60 minutes. Yet only a small portion of our patients are getting treated in time, okay? About less than a third by conservative estimates, by strict inclusion criteria, are getting thrombectomy. And why is that? Well, I think we play a large responsibility for that in the emergency department. Maybe we failed to get vessel imaging up front. Maybe we didn't recognize that this was a stroke. But I certainly think that inefficient systems of care are playing a large role. One study showed that aspects decay during interfacility transport occurred in a third of patients, making them ineligible for thrombectomy. This is a problem, and we need to improve that. So we looked in Rhode Island. We said, okay, if we're halfway between a primary stroke center and a comprehensive stroke center, and this is a likely large vessel occlusion, how do we prevent the ambulance, or rescue as we call it, from driving away from the comprehensive stroke center, only then to have to turn around and go back? That's minutes lost, that's neurons lost, right? And I think the answer clearly is in field triage. Although some of us would like one, we don't yet have a mobile stroke unit, nor do we have centralized or coordinated dispatch, as you see in other systems. We don't think, some others have shown, that mobile endovascular teams are a good solution. We don't think that's the right solution for us. And so that leaves us with pre-hospital severity scales, and he outlined a number of them. Now, he seems to think that there's a vast difference in performance between them, and I'll say there is somewhat of a difference, but this study shows us that, pick your scale. Your over-triage rate is about 50%, and I hope to make the case that that's not that bad. And that's just for large vessel occlusion. If you lump in all the hemorrhages or the other comprehensive stroke center appropriate patients, it's better than that, right? And the LAM score, the LA motor score, which is what we adopted in Rhode Island, is among the simplest and easy to use. And this study showed that on the whole, about 5% of patients will be diverted away from a primary stroke center when they're TPA eligible, TPA candidates, and about 5% will not be rerouted appropriately because of presenting with atypically mild symptoms, so a falsely negative scale. So about a year ago, we in Rhode Island, we met at the Rhode Island Stroke Task Force level, led by Arshad Iqbal from Kent Hospital, and representatives from every hospital around the state convened, and we agreed to use the LA motor score of 4 or 5 to reroute suspected large vessel occlusion within 30 minutes. So the Mission Lifeline stroke wasn't out yet, and that suggestion is only 15 minutes. We went with 30 minutes just in keeping with existing destination protocols for trauma and STEMI. And it was the right scale for us. LAMS has demonstrated convergent and divergent validity. It's accurate, it's reliable, and we expect about 25% of all suspected stroke patients will have a LAMS of 4 or 5. So it's the minority of patients. And of those, well over 70% are likely to be deemed CSE appropriate. That's not too bad. And this drip and ship versus mothership question has been modeled by others, and the modeling is critically time dependent on the efficiency of the referral facility. How's the door-to-needle time, the door-in, door-out time at the primary stroke center, and how's the door-to-needle time and reperfusion time at the receiving endovascular center? Also, the reperfusion rates. Are you a highly successful reperfusion facility or not? And what the modeling shows us is that for hospitals like Rhode Island Hospital, which has a 90% successful recanalization rate, the mothership model actually is preferable all the way out to a 90-minute diversion time, right? So we went with 30 minutes. Mission Lifeline's only 15 minutes, but it's likely to be successful up to 90 minutes, right? And the only time that it's beaten by a drip and ship model is if the primary stroke center is highly efficient, average door-to-needle times less than 30 minutes, with average door-in, door-out times less than 50 minutes. Which just, I mean, it's a great goal to strive for, but it's just not realistic right now. There aren't many primary stroke centers meeting those numbers. So it's a no-brainer, right? In order for a drip and ship model to ever be preferable, you need an extremely close, extremely efficient primary stroke center, and you need an extremely far away, extremely inefficient comprehensive stroke center, and that's just not the case. But unfortunately, these models are being interpreted by many as the comprehensive stroke centers wanting to suck up all the region stroke patients and hospital competition, right? But I gotta say, that's not the case, really, and I firmly believe this as someone who works at both centers, that comprehensive stroke centers, one of our primary responsibilities is to reach out to our region's primary stroke centers, help to make their processes better, work together to make stroke care better for all the patients across the region. So this is some of what's being done here in Rhode Island, and I credit our team for their exhaustive work in making this happen. But with these three components, notifying the comprehensive stroke center early for a suspected large vessel occlusion, not confirmed yet, they haven't even had their CTA yet, and then from the door going immediate to CT, CTA, getting vessel imaging up front, and then transferring that imaging via a secure cloud to the comprehensive stroke center where it can be visualized on the smartphone of the neurointerventionalist on call. We've shown a reduction by 40 minutes in our door-in, door-out times, making our drip-and-ship transfer-in patients actually more competitive in terms of time than the Hermes pooled analysis of the 5 large endovascular trials. So I think that's a great accomplishment of how we've all worked together to make our times better. But even so, the mothership model holds true. And right now, saving 10 minutes in a drive time to the primary stroke center is going to cost you an additional 20 minutes on average of door-to-needle time, an additional 90 minutes on average for door-to-reperfusion times for those needing mechanical thrombectomy. So we've been down this road before. Andrew pointed it out. We've done this with trauma, and that's the case. When trauma showed the 25% reduction in mortality for severely injured patients going to a level 1 trauma center, they did field triage criteria as well. Current triage guidelines include 4 different criteria, and their over-triage rate is 37%. It's taken years to get to that point, refinement and so on and so on. I've studied in over 1.5 million patients. I don't think we need to wait 150 years to collect the same data, which will tell us what we already know we need to do now, right? But at the end of the day, this isn't a data duel. This is an ethical debate. So I'd like to credit our Mission Lifeline co-chairs. They were the visionary virtue ethicists, Dr. Panagos in the back, Dr. Peter Panagos, Socrates, and Lee Schwamistadl for knowing the right thing to do from the get-go, right? Let me tell you why. We know severity-based triage offers the most benefits to patients with large vessel occlusion. That's the principle of beneficence, right? It obviates harm caused by stroke progression while awaiting definitive care, the principle of non-maleficence. And lastly, it creates a just and fair system wherein all patients have the same access to specialized care, the principle of justice. We know this is the right thing to do, and Mission Lifeline was an excellent first step in doing so. So with that, I'll yield the podium to my opponent, but please don't hurt me, I have kids.
All right. So let's start with where we agree. And I totally agree that we have got to do something about these inefficient systems of care. You know, and I'm the medical director of a huge stroke network, and this is what I live and breathe every day, how to make this more efficient. I love this McTaggart paper that was published in JAMA Neurology a couple months ago that Matt referenced. This is what we got to do, you know. Let the patient show up at a lower level center, get them in and out of CT, and get them on the road if they've got a large vessel occlusion. I love that concept, and I really think that that's worthwhile. A couple of things, though, I want to mention. So, you know, we talked about the LAMs, and here it is. I talked about how you get a 1 for, you know, drifts down, a 2 for falls rapidly, thresholded at greater than or equal to 4. This is a paper that actually Matt just referenced talking about this, you know, the validity of the LAMs. You know, so this is Jeff Saber's group, Southern California. You look in the limitations. He talks about, well, actually what we didn't do in this, we didn't look at the sensitivity of the LAMs and specificity for identifying an LVO because not everybody did that imaging. And I said, well, wait a minute, Jeff, you actually presented those data 2 years ago at the ISC, and in the derivation, the sensitivity group, or the sensitivity was 81%. In the validation population, if you want to call it validation, it was 74%. But look at the specificity. Specificity went from 89% to 59%, okay? We know that all these screens are going to perform not as well in the hands of real paramedics. So if you think the specificities are bad now, wait till, they get out. Here's Perez de la Osa's, race screen. She presented this at ISC last year. The derivation population, 85% sensitive, 68% specific. This is her presentation, slides from her presentation at the ISC. Sensitivity wasn't that high. It was actually 81%. Specificity went down to 63%. And this is Catalonia, Spain, who's invested enormous amounts of time in training the paramedics, which I don't think most folks are doing. Matt also referenced this study, the ZAL study, and look at what they did in this study. This wasn't paramedics applying this screen. Okay, these screens, they derived the screens from the NIH stroke scale elements that the doctors actually did in the hospital. And look at the conclusion. Look at that last highlighted statement in the conclusion. Our findings, however, would require paramedics to score as accurately as doctors. And this translation is made difficult by the weaknesses in the current scales that need to be addressed before widespread adoption. Okay? So, I mean, we understand there are problems with this. North Carolina versus Rhode Island. You can actually, there's actually a website called Stroke or State Fights where they actually, you can do this kind of stuff. But, and I bring this up because, we got to each figure this out for ourselves. And, if you look at lots of difference from the EMS systems, the number of providers, et cetera, not to mention just the degree of geographic size of North Carolina versus Rhode Island. Here's North Carolina again. We've got, this is actually Telestroke, the big Telestroke system. So we're down there in Mecklenburg County with 21 sites where we do Telestroke at our affiliate hospitals. You superimpose, that's Rhode Island, okay? Superimposed on that. And I'm not doing this to pick on, Rhode Island anyway, but, this concept of statewide protocols, I think is crazy. This needs to be regionalized, and it needs to be done by the regional, endovascular centers. Look at how it aligns. I mean, these things, these regionalized systems already exist. That's how it needs to get aligned. Simulation modeling, and they've done some of this. This is what we need to be doing to figure this out. We said in Mecklenburg County, and this is published in this month's stroke, we said, okay, if we're going to do this, what is the right bypass time? Is it 10 minutes? Is it 20 minutes? Is it 30 minutes? Well, 20 minutes is what would work for Mecklenburg County. So that's what we would do. Then we looked at, what does this really mean in number of patients over triaged? And we look at this, and again, the problem with this is the assumptions we had to rely on were how the LAMs and the race and the CSAT performed in the derivation populations. We know this isn't going to look as good in the real patients. We're talking about, somewhere around 900 patients based on our simulation model being over triaged in a year period. And again, this is superimposed on code sepsis, STEMI, everything else that's going on. Look at the number of minutes there of additional transport time. Again, that's paramedics that can't be transporting patients with other emergencies because they're routing, big issues. I think we need to come up with this concept of number needed to route. What is the number needed to route? Just like number needed to treat, et cetera. I disagree with this statement. I think that the stroke scale is important because we just showed these are going to perform differently. So just to summarize, I think it's premature for wide adoption of the Mission Lifeline severity-based algorithm. I think it's a great first step. But look at this, guys. Let's look at telemedicine. I think telemedicine may be the answer. And I'm talking about neurologist pinged on his cell phone. I know I ran out of time. Pinged by the paramedics out in the field. Look at all these stroke tank studies that we're going to talk about tomorrow. This is what we need to be doing. People need to be testing different models. We don't need to be adopting an unproven model. We need to be testing and figure this out. And our mantra in North Carolina is we don't rely on the sites to push patients to us anymore. We pull them in. And we do that with other novel things. Really excited about a study we're getting ready to start. Catalyze Aladdin, automated detection. If the patient's got an LVO while they're sitting on the table, no matter where they are, get pinged on a cell phone, DICOM reader on your phone, really exciting stuff. So anyway, thank you for having me, and this is a great conference. Look forward to the discussion the rest of the day.
So I think we agree on a lot more than we disagree on, honestly. I totally concur that this is the right first step, and in no way am I taking the position that that we have to adhere to Mission Lifeline to the letter and use it in every system, because we're not doing that in Rhode Island either. But I think we've shown a fairly successful model, and it proves the point that Mission Lifeline it's starting a discussion. Take it back to your system, individualize it, and make it right for you. So let's talk about a couple of Andrew's points. All right, the severity scales are poor tools. We don't know the over-triage and under-triage rate. Well, that's not necessarily true. We have demonstrated accuracy and predict CSC need. That's what's really important, right? Not just whether there's a large vessel occlusion. And remember, let's take trauma, for example. You're involved in a major accident. Your blood pressure is low in the field. There's a lot of blood. You've had a terrible mechanism of injury. Paramedics think you've had a life-threatening illness. They take you directly to the level 1 trauma center. Turns out you have a couple of minor cuts. Your response isn't, why'd you over-triage me? Your response is, thank God, right? And this is a life-saving intervention that we have that's critically time-dependent. And I sort of think it's foolish that we're arguing whether or not it's worth it. So we do see that about 25% of patients are going to have an LA Motor score of 4 or 5. That's what we've chosen to use. And I think you proved my point that the LA Motor score is probably the best of the simplest tools out there right now to use. And over triage isn't bad. It's probably less than 30% on the whole, which is less than existing trauma protocols. Trauma will accept a 50% over triage criteria, and we're already probably better than that. It will hurt low volume centers. I think this is a valid argument. If we've got reduced large vessel occlusions, reduced classic strokes, then we're not going to grease the wheels. We're not going to become more efficient. Well, I disagree. At the Miriam Hospital, one of the primary stroke centers where I work, we have seen a reduction in our TPA administration this year. But overall, our stroke volume has increased, and our door-to-needle times are getting better. We had a 30-minute treatment time yesterday. So we don't need to practice on the large vessel occlusions at the low-volume centers to remain good. I don't think that's a valid argument. And we need to work with CSCs to ensure that there's efficient, appropriate transfer. If anything, the overwhelming of CSCs that we're seeing are due to non-essential transfers, right? Not the hemorrhages, not the large vessel occlusions, but some loose indication transfers. That's what we're currently working through in Rhode Island. Will it overwhelm the CSCs? Well, we'll see. It looks like overall this is a low proportion of patients on the whole. Now, there are certainly about half of patients aren't going to be having a stroke at all, and that's something we need to work through. But it's certainly worth it. Providing EMS and referring facilities with feedback, taking a transparent look at our data in real time and reporting back to our regions is the way to get better. And so we have to implement this and then collect the data and refine and improve. Lastly, it's taking our patients out of their preferred communities for an unlikely diagnosis. I don't think that's a valid argument either. Large vessel occlusion accounts for maybe up to a quarter of all strokes. And the criteria for eligibility for reperfusion is expanding. As he said, DAWN is coming out, Diffuse 3 is coming out. We're going to know that this treatment is effective up to 24 hours in a short amount of time. And you have to get patients to the endovascular centers where they can do penumbral-based imaging early to include a larger proportion of these patients. These are the patients that are going to suffer long-term disability and death. That's taking patients out of the community. This is the best way, by expediting this process, for patients to receive definitive care and make a meaningful impact throughout a whole catchment area and system of care. So in summary, the Mission Lifeline EMS stroke triage algorithm is an appropriate first step. I agree with Andrew on that, and it needs to be individualized to the region. We in Rhode Island are proud of our model and what's being done here, and I certainly am. And I hope everybody enjoys the NECC this week, and thank you for this opportunity.
All right, some outstanding perspectives on certainly an issue that affects us all in our communities. I have just a couple minutes for questions if anybody wants to go. Really? They did that well. All right, I got one. I'll take one. Oh, I got two. Okay. Do I hear three? No. Sorry.
Hi.
Go ahead, Minnie.
Good morning. I'm Joanne Lawton. I'm the stroke coordinator and the director of nursing quality at a small community hospital in Port Jefferson, a magnet organization. And I can agree and disagree with both of you. A primary stroke center, I have a comprehensive stroke center 7 miles away. I am fed by 37 EMS units, all of which are volunteer. To educate them and bring them up to the caliber that they are going to recognize what a large vessel stroke is, because of all the mimics, makes it very, very difficult. You compare it to trauma, there's very little trauma mimics. You compare it to a STEMI, very few STEMI mimics. You can put that patient on a monitor, you get that patient in. Stroke has so many mimics. To educate the EMS is such a monumental task. And I think that's the first step that we have to start with, is getting EMS on board and standardizing their education so that in all areas, whether it's the volunteer or a paid program, everybody is on the same level and recognizing these symptoms and getting a patient into the appropriate center at an appropriate time.
Any comments, Jim?
Amen, I guess, yeah, amen. So a great point, and I'll tell you that in Rhode Island, there's been a really monstrous initiative led by our neurointerventionalists, where they've gone out into municipalities and educated all of our EMS, our first responders. We have a very fragmented EMS system here in Rhode Island, and it's an EMT-based state. We have very few paramedics throughout the state, but we've been successful in this educational initiative by using the LAMS. LAMS is simple. We use the LAMS. So in a patient with a suspected stroke, use the LA Motor Score, and then the diversion protocol. It's not complicated as the example that Andrew showed, and I don't think it should be. I don't think that the pressure should be on our first responders to have to work through a very complicated algorithm. It should just be very simple and very straightforward, and really it's both the responsibility of the comprehensive center and the regional, the primary stroke center surrounding it to educate the community, and we continue to do that. I think we've had over 150 educational sessions so far, and it's still going.
I do like your telestroke for if you had a designated physician on telestroke for the EMS. I think that would be a great project. Thank you.
And I agree. I mean, there are enormous challenges. I can't imagine, all those EMS agencies with lower level, kind of fire-based agencies. You look at the race screen. I mean, are you serious? These guys are going to figure out if it's a left or a right cortical event, and if it's left cortical, they're going to assess for aphasia, and if it's right cortical, they're going to assess for neglect. Come on. It's not happening, guys. In an EMS,
Yes.
It's just not. They're not going to see it frequently enough. So, Peter Panagos, make sure, take all those questions, and then we'll run out of time.
Truly, just in interest of time, I'm going to take just one more question, and then we're going to get on with the next debate.
Thanks very much. So I'm Jane Morris. I'm the medical director of stroke at Maine Medical Center in Portland, and we are very sensitive to our primary stroke centers, and we are packed to the gills a lot of the times in terms of beds ourselves. And I want to know if anybody has thought about, if someone comes to the Comprehensive Stroke Center, they get an evaluation, they do not need to be admitted there, sending them back to their primary center or their non-stroke certified center as a possibility.
Yeah, it's, the term's repatriation, and I know Ed Yalks, they're looking at that at MUSC. I like, it sounds reasonable, and I think that it's absolutely a viable thing to consider. I think a lot of it's going to depend on what is the relationship between the centers. If everybody's within the same system, it's easy. If it's, competing healthcare systems, man, that's going to be challenging.
It's politics.
But yeah.
I'll just add, I grew up 10 minutes from your hospital, so thank you for the work that you're doing. We've talked about it, but we don't have, and I think that the point is Andrew's number needed to route. How many minutes are lost? Is the EMS have to stay sort of to wait to have us make a decision? I think that's something that we can work out down the line, but for us, it's really just getting the high need CSC need patients to the CSC, and those loose indication transfers maybe we can cut down on.
Well, thank you again, gentlemen, and again, my apologies to those that want to ask some questions, but we're going to continue to move along. But hopefully this sparked the initial debate that will continue throughout today and tomorrow as we identify the best practice systems.